as well, but before we go into more of the theoretical derivations, at this point I think we should introduce more details on the respiratory tract anatomy and geometry, because the derivation and the eventual application that I hope to achieve today would need the knowledge of what the different parts of the respiratory tract implies. And the paper that I shared with you guys yesterday, we would eventually be able to connect with some findings from that paper as well. So before going into more mathematics, let's go into the details of the anatomy, and I'm going to write all the details, so feel free to write them out as well. And I shared this particular 3D printed model yesterday with you all. Today I'm going to use some graphics which are included in those printed pages that you have. So you can use them directly to write the notes. Okay, so introduction to the human respiratory tract anatomy. Okay, so the respiratory system, it mainly can be subdivided into two regions: the upper airway or the upper respiratory tract, and the lower airway, or the lower respiratory tract. Now, the upper airway includes our nose. Based on the problem that we are trying to solve, it may include the oral cavity as well. It goes, so the two sides of the nose, they merge together in what is called the nasopharynx. As we go further downwind from the nasopharynx, as the mouth connects with the airway, that is the oropharynx. So nasopharynx plus oropharynx together is called the pharynx. The pharynx leads into the larynx, where we have the vocal folds. So when we are eating, swallowing food, there's a little flap that closes so that the food does not get into the lungs. So after the larynx, it gradually leads into the trachea. Now, when we talk about the upper airway or the upper respiratory tract, it includes that upper part of the trachea and then is it. And then we go into the lower airway, which includes the lower part of the trachea, which then bifurcates to form the primary bronchi. The primary bronchi goes to the secondary bronchi, and they again bifurcate into the tertiary bronchi, and then the generations go on till the 23rd generation, as we saw yesterday. So that is the lower airway. Now, if you look at the work that we have been doing in my group, until now we have been primarily concerned with the flow physics and the particle transport details in the upper respiratory tract. But gradually we are also moving further downwind, and we have some work now on the lower airway as well. And there are some graphics which might make it clear what I mean, but let me first write out the details of the definitions that I just said, and then we are going to move into the visuals. So the human respiratory system can be broadly divided into the upper and lower airway. The upper respiratory tract and I'm going to use upper airway and upper respiratory tract equivalently, they mean the same, but in literature you will see that this acronym is very common, URT. So the upper respiratory tract includes the nose, the oral cavity. Again, in some books you will see that they do not include the oral cavity in the upper in the URT. Reason being, the book might be or the article might be geared towards just drug delivery through the nose, and they don't need to concern about the oral space. But then again, if you are thinking about infection transmission, uh, it is okay if you don't include the oral cavity. The reason being, we just breathe in through the mouth 10% of the entire 24 hours duration during the day. So that's a very small amount of time. But then again, if you want your model to be more precise, you might need to include the oral cavity. So the nose, the oral cavity, the pharynx, which again, as I said, has two parts. The upper part is the nasopharynx and then the oropharynx. The larynx, it, as I said, it includes the vocal folds, but it has many clinical implications as well. So, uh, with different kinds of throat surgeries, the laryngeal region it forms some lesions, some injuries. They almost look like tumors, and that is a very common complication that arises from any kind of throat surgery. So, sending drugs to the laryngeal region is quite critical sometimes. So, the larynx and the superior, that is the upper part of the trachea. So that, in a nutshell, is what the URT is. I brought another 3D printed model. So this was printed in our lab a couple of months back. I'll pass this around, but one thing to appreciate here is these are the two sides of the nose. See how thin the cross sections are. So imagine you getting a cold and the mucus plugs. So it is quite easy to fill that blockage in your nose. And then it goes with the rest of the tract. So I'll pass this around. Okay, so that's the nutshell definition of the URT. Now let's come to the LRT. The lower respiratory tract, or the LRT, includes the lower part of the trachea uh, and the lungs. I'm going to get into the details of the lungs in a while. Now, if you just think about the functional uh, regions of the lung, like what each part of the lungs do, there are three different parts. One is the conducting stage, where the air from the trachea is brought into the lungs. Then the flow gradually transits to the finer channels, and eventually you have the region where there is gaseous exchange with the pulmonary veins and arteries alveoli. So it has three different morphological zones. So the lung is divided into the conducting, the transition, and the respiratory zones. Now, in our models, the work that we are doing right now, I would say we are still in the conducting phase. So, the models that we are building, they include till generation 3 or 4. As we go finer, modeling can become tricky in certain sense, but it may also become simpler in certain sense. Actually, we will see probably by end of today, no, actually tomorrow, that by the time we reach the respiratory zone, the flow becomes laminar, steady. It doesn't have any time variable component. So simulation wise, it becomes easier as long as we know the geometry. While if you think about the upper respiratory tract, even for that matter in the conducting region of the lungs, the DVDT component, the unsteady component could be strong, and there could be some turbulent features. So we have to model the flow accordingly in those regions. Okay, so these are the nutshell definitions of the URT and the LRT. Let's now go into the details of each of them. So first, the upper respiratory tract. Or the upper airway. Or airspace. So, as I said, those include the nasal cavity, the oral cavity. Let me write out the details of each. So this region also goes by the name extrathoracic region of the respiratory tract. I don't think I've ever used this term in any of my papers, but if you read papers with authors coming from clinical backgrounds, you might come across this alternate names for the URT. So first, let's write about the oral cavity. So this is the mouth, sometimes also known as the buccal cavity. So, as a fluid mechanician, let me go a little further back by a few years. The way I started working in this space is during my second postdoc when I was at a medical school, and the position was with the ENT department, ear, nose, throat. But the group that I was working with, they were mostly working with the rhinologists. Rhinology is the science of the nasal pathway, drug delivery. They have to do some kind of surgical correction, those things. So we worked directly with the clinicians. The project was getting funded for drug delivery to the sinus cavities. All fine. So we just dealt with the nose. But where does this oral cavity come in? So we hosted a summer student from Brazil. She was actually a dentist. And initially, as an engineer, as someone coming from my undergraduate was in civil engineering, then I did engineering mechanics for my PhD, did theoretical fluid mechanics, did some experiments in Japan. It was quite odd to me that I'm working in the same lab with a dentist. And then I realized that they can develop these digital models of the oral airspace. And it is important if they do any kind of surgical correction to the oral airspace, and that's done by the dentist. It is important that the airflow is such that there is enough heat transfer or optimal heat transfer with the air and the surrounding tissues. Otherwise, the patient won't find himself or herself comfortable enough. So they are still interested in this kind of CFD simulation of air moving through the oral cavity. So she would develop these geometries before surgery, after the surgery. I think the problem that she was working with was the cleft lip syndrome. So there were models that there were CT scans she collected at her hospital in Brazil, and she developed those reconstructions in our lab and then ran it in patients. So based on if you guys eventually do any biomedical research or if you're interested in this space, you never know what kind of clinical connection you might see, which would need your expertise of this mechanics. So the oral cavity. The next one is the nasal cavity, which is, if you look at the literature, most people are working in this space because, as I said, 90% of the time we breathe through the nose, so it is important for infection transmission. And because most of the initial infective sites in our airway can be accessed through the nose, we are interested in developing breathing models and drug delivery models through the nasal cavity. Also, there are some new applications that are coming up. So, for example, one of the trickiest things right now for drug delivery is to send drugs to the brain. So we have seen that if you access it through the nose, in our olfactory loop, which is the upper wall of the anterior nasal cavity, it is easier to penetrate through that region and cross the blood-brain barrier and reach directly to the brain. It is an upcoming area of research, but so the nasal cavity could be relevant in many different ways. And if we can really control the delivery of drugs through the olfactory route into the brain, this would be a big thing in this field. So nasal cavity, based on the modeling standards, it may just include the central airspace. And by central airspace, I just mean the central region going through the nose without the additional appendages. Now you can see the appendages in this 3D print. So this sac-like structure that is jutting out, or this region under the forehead, those are all sinus cavities. Now there are 4 different kinds of cavities, and we are going to look at them in a moment. But these cavities, they don't take in much air flux. So most of the air that we are breathing in, it just moves through the median central part of the airspace, goes into the trachea and into the lungs. Not much goes into the sinus cavities that are adjoining to that central airspace. So for the sake of quicker simulation, most of the times we might take those sinus cavities out of the model and then model the airflow. But what if you actually want to send drugs to the sinus cavities, which is what I was doing 8-9 years back as a postdoc. The target site was sinus cavity because the disease that we were trying to treat was the sinus inflammation. So then you do have to include these cavities. So based on the modeling standards, it may just include the central airspace or the central airspace plus the sinus appendages. And if we do include the sinus appendages, then that model would be called a sinonasal cavity. So in the letter, we call it the sinonasal cavity. And you can probably sense that once we include those adjoining structures, the airspace becomes morphologically even more intricate and complex. So from the nasal cavity and the oral cavity, now we come to the pharynx. So the pharynx is what we in common terms we call as the throat. And as I said, it has 2 parts, nasopharynx and the oropharynx. The nasopharynx is critical in the sense that most or many viral infections, their initial trigger sites are at the nasopharynx. There are 2 reasons for that. So the nasal lining, starting from the anterior airway to the pharynx, they contain some cell surface receptors, which is what the virus will bind to intrude into the cells. Let's not go into the details, we're going to cover the details later on, but it's the type of the cell surface receptors that dictates which virus would enter the tissues. Now, in the outer part of the nose, we do have a thick layer of mucus. Even when we are fine and healthy, there is a thicker layer of mucus, which gradually slims down as it goes further downwind. And by the time we reach the nasopharynx, it is easier for the pathogens to actually intrude into the tissues, navigating through that mucus layer. So the first infection trigger site is the nasopharynx. for viruses like for example, like for common cold, when you get a sore throat infection, that is actually coming from the nasopharynx. When I started modeling for SARS-CoV-2, I was trying to read the biological literature, and they did some experiments back in the summer of 2020, and they realized that the infection is primarily starting out initially from the nasopharynx, and then it goes to the lungs, of course. But the initial trigger site, the initial hotspot of infection, is at the nasopharynx. So the nasopharynx is important like that. That's the upper part of the pharynx. As we go lower, we come across the oropharynx. Now, the oropharynx, along with this kind of viral infections, right now in my group, we're also working on pox family viruses. So for pox family, we know that the smallpox has been declared eradicated by WHO in 1980. But since we have a lot of biological literature on smallpox, we're actually trying to model the infection transmission process for smallpox. And that actually starts from the oropharynx and then goes further downwind. If our work holds ground for smallpox, hopefully we'll be able to extend it to monkeypox because that is the emerging pathogen. So basically, we are using this as validation, the smallpox data, and then going to the monkeypox. Similarly, if you think about many other viruses, along with other routes for transmission, inhaled transmission could be critical. And the first thing that we need to figure out is what is that infection, the initial infection hotspot in the area. And then you can use your modeling knowledge, fluid mechanics modeling knowledge to figure out which particles, what kind of particles would be ending up at that particular site. Anyway, so pharynx, which is the throat region, between the larynx and either the mouth or nose, is classified into oropharynx, so this is between larynx and mouth. That is one way to think about it because the main airspace, the region where the mouth space connects, we take that region as the oropharynx, or it is the lower part of the pharynx. And the upper part is the nasopharynx, which is the region between the nose and the oropharynx. So this is the upper part of the pharynx. So that's the pharynx. So after this, we move further downwind and then we come across the larynx. So the larynx, as I said, the main important part over here is the presence of vocal folds. Now, the other line of research that is going on right now. So in my group, I mostly look at inhaled transmission. So we are breathing these particulates inside our system. But folks who are looking at what is expelled out, they are also really interested about this particular region because as we talk from our vocal folds, they move, right? And the particulate size distribution that we are injecting out as we speak can be traced back to what kind of fluid separation is happening near the vocal folds. So if you look at some relatively recent papers over the last 2 3 years from Howard Stone's group at Princeton, he has done some work on the fluid mechanics near the vocal folds. So this is important for modeling particulates spread in the room as well, because those particulates are coming from that primarily. They're also coming from the upper aspect, because as the air brushes past the mucus, there is also some fluid fracture going on, and then some particulates are being generated from the upper respiratory tract too, and even from the oral cavity. And finally, as we and Howard has done some work on that as well, as we move our lips, as the lips separate, there is again some film formation which leads to tiny aerosols expelled out into the air. But anyway, so larynx, which is the constriction to the trachea and contains the vocal folds. So this constriction part is also significant in the sense that, and we will see this tomorrow. The airspace, if you think about the mean airspace, the cross-sectional size stays very consistent until it hits the larynx. And then there is a very sharp narrowing in the cross-section. And then it again diverges out at the trachea. So because of that converging tract and then a diverging geometry, we see very strong vortex formations just downstream from the larynx. And those vortices are strong enough to impact local particle transport. And that is another main thing that we are working on in terms of what are the dominant structures from the flow field in the respiratory tract that can impact particle transmission, be it for drug delivery, be it for infection transmission. So this is the constricted region just before the trachea, so to the trachea, and contains the vocal cords or vocal folds. So during swallowing, as I mentioned initially today, so during swallowing, a trap door it's like a flap called the epiglottis opens up and covers the opening into the larynx. To avoid food or water from entering the lower airway. So this is what it should be happening ideally, but still we do choke, right? We do choke on our food, we do choke on liquids, and even if we don't choke, there is a mechanism called aspiration. So there could still be some liquid components that might be finding their way into the lower airway, which could be relevant, especially for infection transmission. For example, as we know that the initial infection spots are in the URD, the upper respiratory tract. So think about the situation where there are some infected regions in the upper respiratory tract. Now, these are all covered with liquids. As we breathe in, there is some viscoelastic stretching of those liquid layers, those mucus layers, and they might separate as the liquid separates from the cavity walls. Now, where is that liquid going? They might be getting swallowed, fine, but if they're not, they might be getting aspirated into the lower airway, and they can carry a high concentration of pathogens from those infected upper airway sites directly into the lungs, which can lead to secondary infection. So that is one possible mechanism. Also, when someone is sleeping, we aspirate more. And that is another route through which liquids from the upper tract can enter the lung. If those liquids are infected, that leads to a mode for secondary transmission or secondary launching of infection in the lungs. Okay, so let's now share this visual with you guys. This is included in the printed pages that I shared with you. So this is the upper respiratory tract, basically. So if I take a vertical cross section through this model, this is what it would look like. The nasopharynx, as you can see, is over there. This is the mouth space, so it connects with the main air space here. So whatever is above that is considered typically the nasopharynx. I don't think have marked the oropharynx here soon, but the oropharynx is this region, and then this is the larynx, and then after this constriction, we go into the trachea. The simulation that I'm planning to run with you guys in this class would include a geometry that is still over here, till the base of the nasopharynx. And that geometry that I built was meant for drug delivery in the sinus cavities or somewhere in that region. So I did not include the rest of the geometry, but we have other works, and you are going to see some examples as well where we go further down way into the lungs. But since the geometry that you are going to simulate ends over here, you won't come across this strong vortex region that emerges here because of this narrowing. There is roll up of fluid layers, and we get some very strong vortices over here. Okay, let me write a few comments over here. So these are the URT regions. So in this course, we are going to model the inhaled airflow and particle transport focusing on the mechanics in the upper respiratory tract. The geometry that you are going to see would have its lower extent as over here. So the outlet for the flux, so the inlet would be at the nostrils. So this would be the inlet. The air goes all through, and it escapes the geometry that I've built for you guys through this outlet. Now the oropharynx is this region. Basically, this part is the oropharynx, and let's call the pressure at the inlet be P in and the pressure at the outlet be P out. So in the simulations that we are going to run, we are going to assume that P in is 0 pascals, and the flow being driven by the pressure gradient, we are going to assume some negative value for the pressure at the P outlet. And I think we are going to target a particular leading weight. So the simulation, the scheme is going to iterate over that delta P to eventually achieve that particular flow rate through the nasal cavity. So the flow would happen, the flow would be pressure gradient driven. So in this graphic, P in would be greater than P out, and typically we enforce P in as 0 pascals and P out some negative value. We are not looking at simulating the flow field outside of the nose, so it doesn't really matter what we take as P in. It's just a data base pressure. But if you're actually going to model a person sitting in a car or inside a car or in a room, you might have to think about what the precise value of the P might be, because then your take-home pressure is somewhere else. Okay, so the P in is obvious, it is the pressure at the nostril plane. Now the P out, I call it the pressure at the nasopharyngeal outlet. So the geometry that I think is shared with you guys, the anatomical part ends over here at the base of the nasopharynx, but after that I have included a straight tube that goes vertically down, just to make sure that the flow is well developed at the nasopharynx and we don't really come across any kind of end layer effects over here. So that straight tube that you will see is not anatomical. It is just to make sure that the field is well developed at the nasopharyngeal airspace. But if you are doing something further downwind, of course, you need to include all the other details of the anatomy. Okay, so this was just a cartoon. Let me now show you some pictures from the actual CT-based geometries that we have built. And the model that you guys are going to work with, I think it's the second one. But before that, this is a geometry that includes the nose part is from that same person, but the nose, the outer nose, as you realize, is not important for this model. We just need the internal airspace. But all this green, that green region over there, the red region, and for that matter, this top yellow part over here, these are the sinus cavities, and also this yellow region are the sinus cavities. So let me mark them out here. So this is a sinonasal geometry, which includes all the sinus cavities. So this is the frontal sinus. So until now, I think I've looked at over 200 sinonasal reconstructions from subjects. The sinus cavity does not look the same across any two individuals. It's all different. So some people have sinus cavities that are very tiny. Some have sinus cavities that almost look like the big horns of a deer. Now, some people, as we know in our family, some are prone towards getting headaches, some are not. So if the sinus airspace is tiny, that means it is easier to get occluded with mucus over there, right? And once that happens, that's when the person gets the headache. So the kind of physiological reaction we get once we get a cold or get a fever, that is very much dependent on the details of our anatomy. Thankfully, from our CT scans, my sinus cavity is wide enough, so I don't get headache that much. But my wife does. So I did not collect CT scans for her airspace, but I presume that it is smaller than mine. So this is the frontal sinus, and another interesting thing, some people. So these are our nasal cavity has two sides, right? They go into this sinus cavity. So that's why I said these are like horns. So some people might have a smaller frontal sinus on one side and a bigger one on the other side. So that happens as well. So it's nothing is symmetric as such. So for example, in this individual, let me see. So if you check this model again, you will see that the right side has a bigger frontal sinus than the left side of this person. In fact, let me see if I can use the laser pointer. That's why I asked you. You have to come closer to. Anyways, so that's the frontal sinus. Now, this region over here, this yellow sacs, they are the ethmoids, or the ethmoid sinus. So there's a little collection of a number of little small satellite structures, and together that entire region is called the ethmoid sinus region. Then this single bulb-like structure, so this is where the two sides of the nose they have merged together, and then there is this cavity at the back. So that is called the sphenoid sinus. And this structure over here is called the maxillary sinus. So again, if you look at this geometry, these are the two big sacs that are on two sides. So these are the biggest sinus cavities, the maxillary sinuses. There's one on each side. Again, nothing is symmetric. The volumes of the maxillary sinuses on the two sides could be different for any individual. And when someone gets a cold, there is mucus inside. When we collect CT scans, we can see that the sinus has almost disappeared in the sense that there is mucus inside the cavity and there is hardly anything from there to move through. Another funny thing once happened. So anyone here does nasal irrigation, saline irrigation when you get a cold, like taking salt water and run it through your nose? So that's a valid treatment technique where you take in salt water through the nose, you drain it out to the other side. So it helps to disinfect, clear out some of the mucus. So once, while I was doing postdoc, we collected CT scans from this person, and then when we got the scans back, we saw that the bottom layer of the sinus is a plain, straight, thin surface, not anatomically curved like this. It's just a single plane, smooth single plane. Quiz for you guys. Why do you think that happened?
Maybe there was some water remaining from the scans.
So the water was residing over there. CT scans, when we got the images back, they're less than the radio density, right? So the radio density here is equivalent to the Latin space. So we saw that there is something over there which has a very flat surface. And initially we did not know that the patient was doing this irrigation. It was not recommended to him. And the doctors were confused as well. But eventually we did realize that there is the water inside over there. So those kinds of funny things can happen as well when you collect these medical scans and you try to build the geometry. Okay, so, but as I mentioned before, that most of the times, especially for infection transmission studies, we don't include the sinus cavities because the target sites of those pathogens, they are not in the sinuses, and we can remove the sinus cavities and just focus on the central air space. So very little air enters the sinus cavities. Which, by the way, let me mention one more thing over here. Because anyways, for any healthy subject, very little air would enter these cavities. And the biggest cavity over here are these maxillary sinuses. For some people, that entry of air into the sinus cavity is even less than any other healthy subject. And as a result, they might need some kind of surgical correction. So the surgeon would actually open up the entry into this maxillary sinus to make sure that more air goes in. Because otherwise that patient is getting infection just from lack of aeration between the sinus cavities. So that happens as well, and we can get those information through this kind of digital models. So very little air enters the sinus cavity. So unless we are deriving vertical transport or flow parameters at the sinuses, we typically delete these sinus appendages. while developing the respiratory physics model. Another critical thing over here is when you get the CT scans, I think all of us here have some kind of physics, engineering, chemical engineering, mechanical engineering background. We don't have the knowledge of the anatomy to do the segmentation from those scans and build geometries that are anatomically accurate enough. So if at some point you do work on spaces like this, maybe not even the respiratory geometry, some other organ in the human body, it is important to get feedback from the clinicians. Make sure that the anatomy is correct. And that segmentation process is painstaking. So typically when we look at the CT scans that we have collected, they get images at different penetrative depths through the entire head. So based on the size of the head, you can uh, use around 200 to 300 such slices. And then we have to digitally figure out where the airway is in each of those image scans and then build the model. And as a result, when we are looking at a particular scan, we need to know what is the airspace, where are the bones, where are the tissues, and that needs some medical knowledge. And that should be done in collaboration with the doctors. Okay, now for the simulation that we are going to run this week, hopefully, we are going to use this particular geometry. And as you can see, this does not include the sinus cavities. This is just the main central airspace. And we, along with running the simulation, which is going to include all these morphological details, we are also going to develop a theoretical model to study transport parameters on this geometry tomorrow. But in the theoretical model, we of course cannot possibly include all these different details in the anatomy. So there we are going to use a single cylinder system that goes with a similar curvature and essentially track a flux that goes like this. And we'll see what happens if we do that and what kind of differences we might expect to a full-scale 3D CFD simulation. So this, for the theoretical model, which we are going to do tomorrow, for the theoretical model, the highlighted region serves as the model inspiration. And this is, as I said, is the nasal geometry after the sinus cavities are removed. Now, someone asked yesterday whether these structures, these walls, they are moving, they can move. Now the question is, do we need to include that in our mechanics guided modeling? Uh, the answer is not obvious. It depends on the time scale of that motion. So when you think about particle transport, that transport happens over a very short time scale. And most of these movements, they happen as we inhale in and then we go into the expiratory phase and we expel the air out. So the time scale of that motion is much, much longer than the time scale of that particle transport. So most of the times, we assume that the system is rigid. Another argument towards assuming that is, these walls are mostly built of structures that are rigid, cartilaginous, bony structures. And the mucus, one may argue that it's a soft solid, you can assume it as a soft solid. What about it? Now, the mucus the way it moves, the time scale of that motion is also much slower. So typically in a day, we swallow. Anyone wants to guess how much mucus goes through our respiratory pathway in one single day when we are healthy? Around 2 liters. So we move 2 liters of, we generate 2 liters of mucus, and then they move through our respiratory system. But that happens over 24 hours. So think about an aerosol or a droplet impacting on that mucus layer. So that time scale is much smaller than the time scale of motion of that deciding mucus. So typically we take static rigid walls in our models, and that's what we are going to do this week as well. So the airspace, is enclosed by rigid cartilaginous and bony structures. As a model idealization, we will consider a rigid geometry while running the analysis and simulations. Okay, but then again, if you are actually looking at a problem where you want to capture that time-dependent effect of movement of structures, maybe not in this region, if you are going further downstream, you might want to capture the motion of the local rods, then of course, it's can. Yes.
By taking the CT scan, what is the state of the person? Is he asked to
The cities, the image extraction takes us over a snapshot of a second. So it's just a snapshot in time.
all the slices in a snapshot?
So we don't see any kind of movement or blurry effect while taking the scenes. Okay, so anyone here has seen any human cadavers? Dead human tissues? No one? Okay, so I have a gruesome picture in that case for you guys. So this is cut through to a real head. It's slightly old, the head, as you can see. But one thing that struck me when I first saw this is a picture that I took quickly, is how tiny the cross sections are. And we don't appreciate that when we are looking at these digital models and we zoom out, zoom in, and look at them in our computer screen. We don't realize how thin these cross sections are and how tricky the flow physics could be in this kind of region. So over here, this is the upper airspace with this being the mouth. You can still see some tooth over here, and then it merges together. The epiglottis is coming up over here, and then it has degraded a little bit, but it's still there. Now let me share a funny story over here. So when I was a postdoc at UNC Chapel, we once designed a project which would need. So we were trying to develop CFD models of airflow through cadaveric heads. Cadaveric heads are easier to deal with because unlike someone who is living, you can move the head around, right? In different orientations. So we decided to collect cadaveric heads. I think it was in December. We wrote the proposal that we need 40 cadaveric heads. And the start date of the project was in June. And then it was submitted and eventually it got funded. So the first gruesome detail is when I was writing the proposal with 40 heads, and that project started in June, those heads were still living on someone's body. So that was the first gruesome thing. So we were talking about getting cadaveric heads in December for project the steps next year. The next funny thing that happened, so the heads, some of those heads were collected at Duke Hospital, some were collected at UNC Chapel. So Duke, everyone might know, it's like around 40-minute drive, 40-45 minutes drive along the interstate from USC. So me and another medical resident who is very
These two were donuts or like some sort of bond size?
yeah, some organ donors. Yeah. Yeah. So we drove our car on the interstate to get those heads. And on the way back, in our front there were 40 dead heads. And the resident was driving and he was speeding. And we got stopped. The question is, I am just an engineer. He's a doctor, but it's not a full-fledged doctor yet. And we had like 20 dead heads in our trunk. The police did not open up our trunk, but who knows what could have happened if he did. So yeah, so this is a cadaveric specimen of the URT, and clinically it is called a sagittal cross section. By the way, is there any medical hospital nearby which where you guys collaborate with, can collaborate with?
Like one of the professors collaborates with PGI.
Okay.
This is a private hospital, so there is a private hospital called Max.
Yeah.
Some of the doctors study in PGI, so they kind of interact with each other.
Okay. So if you are really interested, maybe as PhD students, even in your spare time, go try see the cadaver lab, and just seeing them can give you new ideas of engineering physics research. Hopefully.
Two of the professors work in like related to bone mechanics. They have collaborations with PGI doctors.
Okay. I actually like if you guys ever visit my lab, my office, not my lab, in my office I have a real human skull. So the American undergraduates, they find it funny that I have a skull in my office in a mechanical engineering building. Okay, so are we going till 11 or 10:30 now?
I mean, it is started with the break.
Okay, so I'm done with the upper respiratory tract. The next thing that we're going to move into is the lower airway and the lungs. So maybe we break for now and then come back to the lungs.